Technique, the process. We start today with the dynamic part of technique. Last two classes, we
It's
started.
okay.
Yeah, yeah.
Thank
Last two classes we saw the static part of technique, the frame. Now we'll go into the dynamic part of technique, the process, how things actually happen in the therapy room between the patient and the therapist. And in that context, what are the important variables? What are the important concepts? So the first concept is self-evident that analysis works. When you have a problem and you set your mind to it and you understand it deeply, that itself enhances your capability to manage that problem, and that insight and knowledge reduces the anxiety related to it. Analysis also in very slow doses releases the affect, and therefore many people feel better after talking about something, and people will feel even more better if they talk in a safe, uncritical, amoral, accepting environment. It enhances the efficacy of talking in terms of healing. Second is behavioral interventions also work. That when somebody tries to do something, if it is mild or moderate, it definitely helps. If it is moderate to severe or severe, then it's difficult. But living out an insight also helps. It consolidates on the gains or brings up problems on the way, which can be then analyzed and solved. So these two are self-evident givens, but for the sake of mentioning, I mentioned it.
you.
Now we come to the first important concept in the dynamic process of therapy, and that is movement of affect. This fundamental characteristic of the psyche leads to 100 other concepts, movements, processes, interventions, and so on. If movement of affect was not possible, many problems would not arise and many healing interventions would not work. And many of the strange occurrences in the therapy room would not occur. Let us say you develop any affect, say anxiety related to a person X, and if the situation in the psyche was such that anxiety associated to X will remain static there, it will not move to anybody else or anything else. If that was the situation, displacement, transference, counter transference, projective identification, none of this would happen. So the fundamental fact of the psyche, which is a given to us, it's natural that there is a movement of affect possible in the mind from one object to another. And the movement of affect is also possible in the form of catharsis. And the movement of affect is also possible in the form of cathexis, which is to load the object further with affect. So loading, unloading, and moving to something else, these three fundamental movements of affect are at the bottom of so many games which are on in the psychic world. Now let us look at some different types of movements of affect. The first movement of affect is a generic movement of displacement, that affect is just displaced from one to the other. For example, somebody is angry at his boss and is going back in the car to his home. In between, he stops at the petrol pump station and he gets into a fight with the petrol pump attendant. It's a displacement of affect from the boss to the petrol pump attendant. This displacement of affect can also be seen in pathology. For example, the whole area of phobia. Essentially, in phobia, what is happening is an innocent object has been converted into a phobic object. And why is that happening? Because the innocent object is now loaded with anxiety. That anxiety is coming from somewhere else. It may be unresolved Oedipus, it may be the split open, it may be any other source. It may be signal anxiety of repressed emotions coming up. Whatever the source, but something is displaced onto an innocent object and then it becomes a phobic object. And when a reverse displacement happens, the phobic object again becomes an innocent object. Similarly, you can have generation of affect and ungeneration of affect. Somebody tells me that X spoke very bad about you and I get angry with X. And then somebody comes and tells me, don't believe A, he is lying to you. Actually, X is a great friend of yours. And suddenly all the anger towards X goes away. So what was generated is ungenerated by cognitive understanding. That also is one movement of affect, the generative movement of affect. But usually what we refer to by movement of affect is not generation and ungeneration. It is movement from one object to the other. Displacement, as we saw in phobia, is very, very common. Now, one particular form of displacement is transference. Like these are all movements of affect. You can have just a general displacement. You can have a particular kind of displacement which you call transference. And in transference, there is a movement of affect, there is displacement, but there is a role involved. It is a role-based displacement of affect. Displacement of affect also is seen in fetishes. That somebody has a fetish of footwear, somebody has a fetish for something else, and that also involves displacement of affect. So displacement has two, it has hundreds of applications, but two major applications in pathology: the phobia, the whole spectrum of phobia, and the whole spectrum of fetish. That is like out and out displacement. Yeah. Displacement. Sorry, can't hear you. Can you say it again? Displacement, you said. Sorry. In the thing. Can you just type it in the message? Yes, sir. Yes. In transference, we see a role-based displacement. You can have a general displacement. It's a very generic word. Movement of affect facilitates a phenomena called displacement. And displacement can happen in various ways. It can just be a general displacement as we find in phobia or fetishes, or there can be some specific types of displacements for which we give different names. So one name is transference, where there is a role-based displacement. For example, the patient starts developing feelings towards the therapist as he would have towards the father or mother. Now that's a role-based displacement, which we call transference. Now, how do you make out whether the transference is there or not there? One way is to directly look at what the person speaks. At times, he explicitly will tell you, at times I find you exactly like my father. At times, you have to deduce and make it aware to the person that he is projecting something, he is transferring something, but that is not true. And you may make an intervention to say, you don't have to hold back, I am not your father. So by act of interpretation, you are making it clear to him that transference is on. And it has to be undone so that he can feel free to talk to me. At times, you make it out only by counter transference, not by words, not by actions, but by counter transference. When it is very subtle, what happens is the transference solicits counter transference from the therapist. And that is something inside of us. And if we are aware enough, and if we are partly knowledgeable about ourselves, we can distinguish between counter transference and our own material. Because this is a very important element, that we cannot attribute our own evocation to transference. For that, we have to undergo our own analysis so that we are clear about ourselves. And this is why it is so necessary and mandatory in all schools of psychoanalysis to undergo your own training analysis, so that we are able to be clear what is counter transference and what is evoking in me because of myself. So everything that is evoked in me is not necessarily because of the patient. Part of it is because of me. And as we understand ourselves better, we have more supervision, we do more practice, the me part of us reduces in therapy, and we become more and more of a real blank screen. So counter transference is something we directly feel, and from that we deduce transference. So subtle transferences are deduced. We don't feel it directly, we feel counter transference. We will go slightly in details of transference, but for the moment, just to introduce the concept. Projective identification. This is different from counter transference. It's very important to distinguish. Most people are not able to distinguish. If the patient makes a father transference onto me, I start making the son or daughter counter transference to him. Which means the stimulus and the response are related to each other, but they are not the same. They are completely different. What is coming to me is the father transference. What is going out of me is the son or daughter counter transference. So if you look at input and output, they are radically different. It is like A coming to me and B going out. Right? A comes to me and B goes out. A and B, stimulus and response, are completely different. Transference and counter transference are related to each other, definitely. One is soliciting the other, but in content terms, they are very different. But in projective identification, the content is the same. If the person feels anxious and he cannot handle it, he will put it into the therapist to manage that difficult feeling for him. So the therapist will start feeling anxious. It is not A to B, it is just A directly put into the therapist. And this does not have a role part to it. Projective identification can just be an effect without the story of any role. This can also be used to communicate something, because projective identification is a very primitive form of non-verbal communication before language begins. that when the child is distressed, it puts that distress feeling into the parents or caregivers, and they instinctively come to know that the child is distressed. And often they ask the child, "Are you hungry?" And the child says yes. Yes, please.
Is it okay to ask the patient, have I done something that, that justifies you feeling this way toward me? Why am I feeling angry toward you?
Say it again. I think you'll have to write it. The voice is going off again. Huh. Both can be possible. If you are feeling angry towards the patient, uh, it can be projective identification. It can also be counter-transference. Same for any other effect. Sorry?
Identification by the patient to
Yeah.
me.
It
So
can
I feel angry.
correct.
Or something that be this thing
Sir, you will have to write
displacing.
again
Writing,
the
sir,
please.
displacing it to the patient.
Welcome, Madhusudan. So any effect that you uh, feel for the patient may come as a result of many things. One, it can be projective identification from the patient. Second, it can be your counter transference to something that the patient is transferring. Or it can just be your material which is evoked because of something the patient said or the patient did, and that by law of association evoked something in you. So the effect that we feel in the therapy room can come from all the three sources.
Yes.
Now, let us go into projective identification for a moment, slightly spend some time on it.
Yes.
Projective identification is where the patient puts things into you. The most simple part of it is in the therapy room, you start feeling the anger of the patient. And you start getting angry towards the patient. So if you start getting angry, keep observing it and tell the patient, why don't you accept the anger which is activated inside of you? He says, I don't have any anger. I don't feel any anger. Tell him, you're putting it into me. I can feel that anger. Why don't you just accept anger which is coming up in you? Because what the patient is doing is multiple things. One, he is putting into you what he himself doesn't want to accept and process. Two, he wants you to get angry so that he can tell himself, here again it goes. The authority figure is going to attack me. He is not a safe person. And there is no hope of getting healed here. He will repeat the past patterns. He is laying the foundation of a reenactment. Another way, you can have delayed projective identification, meaning It does not occur to you in the therapy session. After the patient leaves, you feel it. It's delayed projective identification. This delayed projective identification can come up in terms of just an affect, your mood, visuals, or at night, even the dreams. He can leave you with a dream to process. And in next morning, when you remember the dream and bring it for dream analysis, you realize this is in no way my dream, this is his dream. He is using my system to process his psychic entities. And that's a very strange and mystical part of the whole process. We don't know how it happens, but there is no doubt that it happens. Because it happens again and again to so many people who do deep psychoanalysis that the phenomenon's occurrence is not in doubt, just the explanation we don't have. Data is not in doubt. Let me give an example. After a session with a person who was schizophrenic, I started having a very vivid visual of a heap of thick silvery worms slimily moving over each other. Thick silvery worms, a heap of them, and all of them moving over each other, very slimy and silvery. And that kind of vivid visual was never mine. It has never been again, it has never occurred to me. Now that is something the patient has put into you to understand. And this is an imagery which he has not articulated. He has, without using language, put into you. It's a non-verbal part of therapy, a deep part of therapy. A therapy, part of therapy which is happening outside of language. That he has put those things into you so that it occurred to me almost 4 hours after the therapy session was over. And in some cases, they will leave you with a dream which is not yours, but you will dream it for them. So this is the strange and mystical part of projective identification, because it's a very primitive communication of pre-verbal, pre-linguistic part of the infant. Projective identification also leads to transferring difficult states. For example, if somebody puts a lot of hatred into you, as a therapist, you start feeling sleepy. So when you start feeling sleepy, be very careful. And I have made this intervention often, and I ask the patient, towards whom are you feeling so much of hatred right now? The moment I felt sleepy. And in most of the cases, the patient is able to recognize after a few no's. Initially, he says, no, I'm not feeling any hatred. I said, just look inside and see it. And in most cases, they find hatred. At times, they make you feel anxious because they want to tell you, this is my problem. And the conscious articulation is completely different, and the unconscious message is completely different. And this, they may communicate to you that this is where they want the therapy to be focused. That you may be doing many right things, but not the central thing. So they trust you, but they want you to recognize the center of the whole thing. That my central problem is X. You are solving A, B, and C. All of that is very good. I am helped by therapy. I am getting better. But I want you to focus on X and not A, B, C. Sir, a cup of tea. It's okay, perfectly okay. So let me give an example of how this is communicated. I'll give two examples. Very vivid examples I can't forget. One patient of mine, I used to see once online and once offline, twice a week. And it rarely happens that I would forget a session. But in his case, I would forget a session. I forgot once and actually I had to apologize. And then I said it cannot happen. This has never happened before. And I then reflected upon it to realize that this was a communication, a projective identification to say, everyone has forgotten me. Nobody acknowledges my existence. Nobody acknowledges my importance. And I'm always like a piece of furniture in the corner of the room, unrecognized, unaccepted, unacknowledged. And this is my core problem. The first thing I want is the acknowledgement of my existence so that you don't forget my existence. And therefore, this is a case not of interpretation, but of holding, of containment. It calls for a Cohesian approach rather than a Freudian-Kleinian approach. That will come much later. And that is what then worked. Let me give another example, which recently happened when I presented a case for supervision. In that transcript, in that session, what happened was the patient related to me a visual. He did not say this was a visual or a dream. He said this is a fact. But the fact was vividly visual. The fact was this. He said the ancestors of one of his relatives, the ancestor of one of his relatives was a minister of a Nawab in Gujarat. And it was a time of 1857. Britishers had crushed the revolt. And now they were making a list of who is on Britishers' side and who is on the enemy side. And anybody who was on the enemy side would be shot dead or they would be put on the cannons and blown off. The Nawab came to know that his name was also on the list of the traitors, according to the Britishers. One of the British senior officers was coming to a kingdom near to the Nawab's kingdom. So the Nawab entrusted this minister the responsibility that you go and meet that British officer and convince him that I am on their side, not on the side of the revolutionaries. And he said, this is so urgent that whatever happens, before you reach here, I should have the information that whether I will be saved or I will be killed, so that I can run away before you or the Britishers reach here. Now, how do you make it possible in that era? So what the minister did was this. There was this distance of 28 kilometers. And on every kilometer, he made a man stand with a torchlight, mashal. And he went to the other corner and talked to the British officer and convinced him that we are on your side. And when the name was struck off, he asked the first person to light the mashal, which was ki work has been done, a signal. And just as he would raise the torch, the person after 1 kilometer would also light it and raise it. And then the person next to him, and it would finally go to the 28th person. And therefore, in a few minutes, the information would travel 28 kilometers. This was the story narrated to him. Now, this is a very vivid visual. You can't forget this visual. So we took it up to find out what it means. We could not find out in the supervision session. Later on, it occurred to me. What does it mean? What it means is this, that The patient is feeling persecutory, annihilatory anxieties inside. He is terrified of persecution at the hands of the bad objects. The Britishers are the bad objects. And these bad objects are omnipotent bad objects. There is no question of escaping them or fighting them back. There are persecutory anxieties deep inside the unconscious. Number two, he wants the therapist to be the minister and somehow negotiate with those bad objects to make them harmless or to make them realize to leave me apart safe. In some way to neutralize the persecutory anxiety of the omnipotent bad object and its attack. Third, not only has the persecutory anxiety to be healed, but after it is healed, the effect of that healing has to spread across the psyche. So the mashal has to be lit at every kilometer of the psyche. Fourth, and very important, the distance between the two ends is 28 kilometers. And this visual came up on the 28th day of therapy. I used to see him once a week, and this was the fourth session, 28th day. So every kilometer is 1 day that is passing ever since the therapy started. And 28 is also important because he was very expressive emotionally till 28 years of age. And at 28 years of age, something happened which was publicly humiliating and shaming for him. And thereafter, he never expressed his emotions. He started repressing everything inside. He would smile on the outside, but everything would be repressed inside. And that in turn created symptoms. Now, this is something that he puts into you by narrating something else, and that slowly it develops in you and you analyze it for him. And what he's telling you is that the therapy has to be essentially be based on internalization of a good, reliable, stable object. The first requirement is of safety and internalizing the good object to undo the early life object loss and resulting from it those persecutory anxieties. That is the center of the whole thing. Whatever you are doing is good, but this is the center. So we are looking at the center of object loss. And in the next session, another object loss came up of a woman he liked. He proposed also, she turned it down, and he had all the projections on her as though she was not a woman of this world. Right? She was like a Greek goddess of the ethereal world. He had all the surreal projections on her. That she was the moon you cannot touch, a completely surreal woman. As Jung would call it, eternus feminis. That every man is in search for and nobody can find it. The eternus feminis. The perfect woman. Who does not exist in reality. So, for him, she was the eternus feminis. That surreal, out of this world woman that he could not have. And the moment he lost it, with that loss, he gave up all his desires. And I am seeing him when he is 49 and he has never worked across his life. Except for 2 small stints of 1 or 2 months, he never worked anywhere. and he does not have any desire which is alive. It's just like a moving corpse with occasional rising of very feeble desire. So I started with this. I said, where are your desires? We have talked about everything, but we don't see your desires. In which corner of the psyche are the desires buried? And why so? And from when has it happened? So that brought us to this, that after the early life object loss, which created this persecutory anxieties, there was another object loss, which led to the death of desire, so to say. And thereafter, a shaming incident which led to the death of expressiveness. So this can be a way of narrating you something and then leaving it inside of you, that you can't forget it. You just keep analyzing it till you are able to decode it. So these are different types of projective identifications. Projective identification can also be done for containment, that the person never had a good container in his life and he is looking for one and he's checking you out. He is checking out, one, whether you can contain, and second, if you are willing to contain. He's checking out both your intention and capacity. First, he will check intention and then he will check capacity. He will make it so difficult for you not to be irritated and angry that you will become irritated and angry, and he will tell himself, I don't have a container here also. So these are projective identification, different types of it. There are happy parts also. You will feel happy like when they are manic. And if they are histrionic, you can feel seduced. If they are very paranoid, you start feeling anxious. If they are disintegrated, you can feel the disintegration inside of you. The disintegration, the chaos, the anxiety. Often when we say something, somebody's vibe is not good, it is our assessment of his projective identification. Yeah, you're saying something. Sir, you're muted.
How come the other person can actually make you feel example before this?
Sorry, sir, can you say it again? Some words were stolen.
Example that you gave before this. From the patient can make you feel like this.
Right. So it's a completely unconscious thing. It is unconscious of the patient talking to the unconscious of the therapist. And the more you have worked on yourself and you have cleared out your own material, more these things can happen and more they can be dealt with accurately. Otherwise, if you are not cleared out, you will be putting things into him. You will make projective identification into him, and that will create more problems for him. Then we come to intervention. Any act that you do of commission or omission for the therapy process to move ahead in some significant way, you call that intervention. Intervention can be an interpretation, or intervention can be silence. Intervention can also be a change of subject. Intervention can also be recalling what happened in the last session. Intervention also can be self-revelation. Intervention also can be bringing the person from there and then to here and now. So anything that you say or consciously you don't say, all of that is intervention. Like, okay. Now, one particular form of intervention is
Sir,
interpretation.
sir,
Yeah.
a second.
Ah,
Just one question.
ah,
So, in the case where the client has no desire,
ah.
he would try to instill the same lack of desire in the analyst out of projective identification. So, what would be the appropriate intervention there?
It will happen in two ways. One is from his case story. We will know that he is not working anywhere. He is not following any woman. He is not doing anything even to heal himself beyond a point except for coming to you. He does not have any deep interest in food, in clothes, in money, in anything. So
So,
his
he would,
case,
sorry, no, so he would also then become actively prevent you from any breakthrough, no?
correct. So what
Ah,
will happen is ki the healthy part of him has brought him to me,
right.
and the unhealthy part of him will stop the healthy part from conquering the rest of the psyche. So both of them are into a self-preservation mode, and it's a contest of power between the two in the unconscious. Now, his case story tells us that we see a dying desire, a weak and feeble desire. At the same time, you don't feel like doing anything in his presence, which happens from projective identification. You feel chaotic. You feel aimless. You feel confused. You don't know where to go, what to do. And then you start feeling helpless. And the helplessness has a very distinct flavor of resignation. Resignation which comes from repeated disappointment. So repeated disappointments will lead to resignation. And that resignation has an element of, a very deep element of hopelessness. But all of it put together, the man still has a healthy part of him which is coming up in a distorted way, in the sense he gets into a manic state. There is a pressure of speech when he talks. In the therapy room, there is a pressure of speech. And this particular person also has cognitive thought disturbance, which combined with the manic mood can falsely give you a diagnosis of psychosis. The differentiating factor there again is something non-linguistic, like the precox feeling. In the presence of a person with psychotic spectrum difficulty, the precox feeling is very different. It's an affective precox. In the presence of a person with cognitive thought disturbance, you feel a precox feeling, but it's not the same. It's a cognitive precox. You feel something is off, but you don't feel it emotionally inside. You feel cognitively something is off, that he is not like me. There is a break between us. So just as you have an affective precox in psychosis, you have a cognitive precox in cognitive thought disturbance and at times in the mental retardation. So that also tells us that in this person something is at work at a very deep level. So then the theory comes in that who talks about cognitive thought disturbance the best? And one of the people is Beyond, Wilfred Beyond. And what does he hold responsible for occurrence of cognitive thought disturbance as a causal factor? And Beyond talks about repressed envy. That repressed envy is most often responsible for cognitive thought disorder. And I have discovered something more, one more factor, which is narcissistic rage. That both of them attack the linking process of thought, because thought essentially means one thought is linked to the other thought. It's a chain or it's a link. Now, if you delink it, you get into circumstantiality, you get into tangentiality and all sorts of cognitive thought disturbances. And this delinking happens because of attack on linking that Beyond attributes to envy. And I attribute, apart from envy, to narcissistic rage. The idea there is, I cannot endure the message the postman brings. I have to attack the postman because I cannot change the message. And the postman is the thinking process. It brings to me the reality of the world, which is unbearable. So you have a person here who is healthy enough not to get psychotic, but not healthy enough to withstand the world and accept it. He is not creating a world of his own. He is just refusing the world as it is. He is not taking the next step of creating his own world, which a psychotic will do. So that brings us to interpretation. Interpretation is a verbal thing, which is used to bring up generally a fact of the unconscious to the patient. That's something that the patient does not know, but is operative inside of him, that is discovered by the therapist, largely using the theory of psychoanalysis. And then it is articulated by the therapist so that the unconscious becomes conscious to the patient. And the act of interpretation can heal a problem, partially heal a problem, or just make the patient understand the problem. And one may require multiple interpretations before healing happens. Interpretation has to be very acutely, precisely calibrated, not to make too deep interpretations in the beginning. In the first few sessions, even if you don't make interpretation, it's okay. You can just devote the first few sessions to trust building, safety building, getting familiar with the new situation, internalizing a good, reliable, stable object, finding a safe place. In interpretation, always go with the model, leaf to the branch, to the trunk, to the root, never go straight to the root, although you may know it. Give interpretation to those who are ready for it. Just because you know does not mean it has to be said. One important aspect of therapy is to hold back our own brilliance. And that is not easy. Our narcissism keeps propelling us to display our brilliance. So we have to keep aside our narcissism and exhibitionism to hold back. And Beyond says something very important. He says, if the therapist can hold back his brilliance, he will see in a few minutes, the patient will speak what he wants to speak.
I think when I feel patient didn't actually respect me, He doesn't think only of me.
Sir, the oral tradition is not working. Yes. Yes. And this brings up a very important element about jargon. That is true. That is true. So silence is golden. Interpretation has to be calibrated. There is an old saying in psychoanalysis, brilliant interpretation and the therapy ended. So we don't have to do it, and everyone does it. When we start off, right, our narcissism and our exhibitionism propels us to display. And only after losing a couple of patients, the wisdom gets instituted. Interpretation may have to be customized in the language of the patient, especially in a country like India, which is extremely multilingual. Interpretation should not be a story. Ideally, it should be one sentence, ideally a short and a pithy statement, something very simple but suggestive. Yes, it has to be customized extremely to the language of the patient. Both language in the literal sense of the word and language in the more metaphorical sense of the word. What he can understand given his intellectual level, his cultural background, and so on. What not to interpret is equally important. Don't interpret too much too soon. Don't interpret what the patient does not have the capacity to process. Don't interpret what culturally the patient is not ready for. And in India, Oedipus is a typical problem. It may take very long time before the patient is ready for it, and many will never be ready for it. They will come to you, you will have sessions, they will feel good, and they will stop the therapy. And you never get a chance to open up some parts you have never opened up. Correct. Don't give them what they cannot chew. Because what will happen is, as a result of that, what they will do, then you will not be able to chew. Interpretation becomes an art in terms of wording it for right effectiveness, right depth, and right capacity. That calibration takes time. Some interpretations may be technical. Some may not be technical, most will not be technical. Some will be suggestions of a strange type, that it's on the borderline whether you call it an intervention or interpretation. It's more like an intervention rather than interpretation. It's like, for example, somebody lists out difficulties of reality about which neither he nor you can do anything. And then we say, and we just accept it. And that itself has a huge effect. And we just accept it. Now, this is a statement, a tool which is used in acceptance commitment therapy. But this statement we take from there. So often we take statements from different forms of therapy, because every form of therapy will have some good statements, which are very powerful, effective tools of interpretation or intervention. For example, in ISTDP, there is a very good tool. The person says, so now what should I do? And you say, only you would know. The patient says, what should I do? And you say, only you would know. Meaning, he is putting projection of omnipotence on you. He is asking you to become the father figure and guide him. And you are removing that projection. You are undoing that projection and giving him back his will. You are not allowing him to be dependent and helpless again, which is what he wants. Or somebody can say, it happened recently, last week. A resistant boy came to see me. Came on his own, but after coming here, when I asked him, tell me something about yourself, what is troubling you? He said, there's no problem. I don't have any problem. So I don't have any problem. Right? Now he has come to you because he has a problem. Therapy, the therapist is not a tourist spot. Nobody comes because the therapy room is so beautiful to see. Right? So people come when there is no option left. So then let us look at two different ways of looking at it. The patient comes and says, I don't have a problem. So ISTDP intervention will be, it's a wonderful place to be. But I wonder, how do you find yourself early in the morning in the office of a therapist? So the first is, it's a wonderful place to be. There cannot be any human being who has no problem. But he says, I have no problem. So you say it's a wonderful place to be. But I wonder, how do you find yourself early in the morning or how do you find yourself in the office of a therapist? Somebody from an existential humanistic point would say, perfectly okay. So let us talk about what you would like to talk. If we can't talk about the problem because you don't have a problem, we can't talk about a problem. So let us talk about what is interesting to you. Let us see how your life is. And they would do a lot of self-revelation about themselves also. Completely different approach. I had a different approach. He said, I don't have any problem. And I said, both of us know it's not true. Right. Both of us know it's not true. So I did not say anything for a long time. Then he said, what are we doing here? I said, I was waiting. I'm waiting for you to say something about what is troubling you. He said, I don't have any problem. I said, both of us, we know it's not true. Now, what is interesting to me is, what stops you from accepting that you have a problem? I think the first problem we'll have to deal with is to accept that the problem exists. That's the first problem we have to deal with. And I wonder what would stop you from accepting the problem, because you know the cost of it. You know the cost of not addressing the problem. You have paid a cost and you're paying the cost. And despite it, if you find it difficult to accept a problem, it means there must be something far more than the cost that you are paying, which is at stake. That between the two difficult things, you are choosing not to accept the problem, even while paying the cost of it. So I wonder what it would be. Only you can tell me that if you wish to. So different people will approach it differently. So you can see the same situation in therapy. Different people will approach differently with different interventions. Similarly, in the same situation, people will give different interpretations. One way to proceed is, as I said, to hold back the interpretation when it is too early, and that is holding. So when you say holding, it's a very important part of the therapy process. Holding means many things. One is to hold back your interpretations for a later date. Second is to provide holding to the patient by allowing him to make projective identifications and be a good container. And containers are of two types: the passive containers, which just hold it, and active containers, which process it and give back the patient good emotions when difficult emotions are coming in. And then later on, okay. So holding is, you just provide holding to the patient by being amoral or critical, not giving interpretations, and you just provide him safety and empathy. So safety and empathy also are parts of holding. It's basically a cohesion concept. And make as little interpretations as possible. Don't speak too much in the therapy session. In 1 hour, if you have made 7 to 10 interventions, it's enough. So we have to be clear, it is not our therapy and it is not a classroom. It's very difficult initially to hold back. So we go into paragraphs and we have to slowly chisel our skills so that from paragraphs we come to sentences. In the initial part of therapy, you will have to speak more and make not necessarily more interpretations, but you'll have to speak more because it's awkward for the patient before the trust and familiarity is established. So initially you may have to encourage the patient, but as sessions pass, you can withdraw, and then the patient speaks more and more on his own, more spontaneously. Containment, as I said, passive containment, active containment. And not feel dysregulated when the patient is saying something which he might be doing just to make you dysregulated. Like he may be speaking something absolutely immoral and he expects you to criticize him or preach him not to do it. But if you can hold your anxiety at that moment and be amoral or critical, will get you much better results. Containment is an underappreciated tool in therapy because it is silent and passive. Whereas interpretation is an overappreciated tool in therapy. because it is explicit, loud, and out there. Containment is what provides safety, acceptance, unconditional acceptance. And in certain states of that containment, what happens is you are just silent, all open, and you allow things to happen. The person says something, and it's obvious for you to say something, but you don't say anything. And you see after some time, the person automatically changes. So what has happened is inside of you, something has happened, and that beyond says is the ineffable O. O is the event of transformation. That you have not put an intervention, you have not done an interpretation, you have been silent, but in certain stages of silence, the person says something which is a problem, which he has not been able to fix. And you don't say anything, you don't do anything, but after some time, after a few sessions, he tells you he has been able to fix that problem. So that is the ineffable O, which happens when you get into certain states, and often these states happen towards the end of the session. That when everything is spoken of, and you are in that silent state, not only verbally, but also inwardly. There is an inward peace and silence in you. That inward peace and silence in you enables more and more of this ineffable O to occur. The event of transformation to occur. And this opens up a large area of what is transformation. And that is a very large area. What is transformation in general, and what is transformation particular to psychotherapy? And what aids and what inhibits transformation? So Beyond has written a book on it titled Transformation. On my YouTube channel, there is a video, what is healing, or how is healing, something of that sort. So there I have tried to reason out what are the ways in which healing happens in therapy. So these are some of the primary concepts in the dynamic part of therapy. Any questions on this? Okay. These are some more concepts, and after that we'll go in details of transference, counter transference, and so on. Yes, it is on my channel. It's titled How is Healing? And it goes into the same thing of transformation in a different way. What all happens in therapy that healing happens. So there's a list of factors, what all heals. And part of it is verbal, part of it is non-verbal. So these are some more concepts, and after this, we will go into details of transference, details of counter transference, and details of silence, the different types of silences. So that is very important to know different types of silences. Because there are two primary types of silences, the silence of the patient and the silence of the therapist. Should we break for a cup of tea?
Yes, sir.
Okay. So let's reassemble at 4 and take it ahead.
Yes, sir.
Some more concepts. First is therapeutic alliance. It is the unconscious alliance between the patient and the therapist, which is in the interest of therapy. It's like a unconscious friendship and unconscious consortium. The healthy part of the therapist and the healthy part of the patient, they come together to build up this therapeutic alliance between the patient. It's an alliance between the therapist and the patient. So this alliance between the therapist and the patient, which is unconscious, is a therapeutic alliance. Therapeutic alliance is strengthened by being amoral or critical, providing holding, containment, safety. Therapeutic alliance is eroded by very harsh interpretations, unrelated talk, converting therapy talk into an ordinary talk, too much of self-revelation, breaking of the frame, not understanding the problem correctly, not calibrating the interventions, too much intervention, too harsh intervention. They all break therapeutic alliance, and this is very, very subjective. For example, if you are dealing with a dependent patient and you maintain silence, beyond a point, it's very difficult for the dependent patient to bear silence. But if the same amount of talking you do with a narcissistic patient, he doesn't like it. He wants to talk. He wants you to listen. So what will strengthen therapeutic alliance partly also depends on the situation. One thing we have to be clear is every act of interpretation chips away at the therapeutic alliance. Therapeutic alliance is that social capital, that psychological capital, which we should not spend too easily. Because if it depletes below a point, the patient will eject out of therapy. And every act of interpretation chips away at the therapeutic alliance. Very good question. Why do we say amoral and not moral? We say it in the context of being critical, not in the context of being moral free. That we are amoral, we are not critical of anything. That does not mean that we are morality free. But we don't impose our morality on the patient. It's also not the case that the patient will be left morality free. He will develop his own set of convictions, knowing fully well the pros and cons, the substance or the lack of substance behind it. So when we say amoral, we are all accepting. There is a very famous statement by somebody, I don't remember the name. It says, I don't consider anything human alien to me. Sorry.
Freud wrote it too.
Okay. That I don't consider anything human alien to me. Now, this often will test our resolve to be amoral when the patient says something which is completely against our morality. Right. Right. So, in most cases, it is good to be amoral and allow by discussion the patient to evolve his own convictions, his own morality. In some cases, this may not be the situation. Some patients will come looking out for a superego. And in such cases, you are taking a moral stance, not necessarily in a punitive, dominating way, but in a soft, suggestive, open way, will actually make them feel better. In the sociopathic range, this will more be the case. Another aspect of being amoral is this. Some people feel very strongly about their moral beliefs, and anybody who does not share it, they will not like that person to be the therapist. So if your moral beliefs are known, many patients you will lose because they don't agree with you ideologically. And very few will be ready to be with a therapist whose ideology is different, because then it's a much more healthier way to do therapy with a different ideology. But very few people will look at it that way because of the projections. They don't want fight with a new father. And that's one of the reasons one should not go onto social media and keep it open. Somebody can make out what is your ideological orientation, and they may not like to be with you in therapy. I lost a couple of patients because of this. They found out something I wrote on Facebook. I don't know how, but they found out. And it was not in tune with their ideological beliefs. So therapeutic alliance is very important. Second, we have cathexis. Cathexis means loading something with energy. In our case, loading something with emotion. Cathexis. And catharsis means removing that loading from that object. So they are like opposites. Cathexis is investing and catharsis is releasing. Cathexis is very important when one is given up out of disappointment and resignation. That one is not ready to invest any more in anybody else. One says, I am done with it. Enough of it. So that is very important. Catharsis is important in most of the cases, that people come with bottled up emotions and they have to be released. And there are two important ways of releasing. People know normally only one way. One way is the hydraulic release, which is release under pressure, which is the typical way of ISTDP, or in a smaller way in psychoanalysis. So in psychoanalysis, classical psychoanalysis, we do it in retail, and in ISTDP, we do it in wholesale. The release of emotions. And that's a very hydraulic release under pressure. It's like I ask somebody, what feelings are coming up towards me in your body right now? And he says, I am thinking of you, that you are a good person. Why should I have feelings? Then I say, let us put all those thoughts aside. Let us look only at the feelings. What feelings are coming up towards me in your body right now? And suddenly a crisis is created. Like if I ask you this the same thing 5 times, the crisis will get created inside. And then I say, why, if you don't avoid these feelings but allow it to flow into your body, how do you feel the flow of these feelings towards me in your body? So then somebody will say, I feel hot, I feel cold, I feel stiffness, I feel looseness, or I feel angry. And then slowly the anger will start flowing into the body, and you can see that clenching of the fist, clenching of hands and legs, and the clenching of the jaw. So that's under pressure hydraulic release, high volume release. In psychoanalysis, we do it by an act of interpretation or by the act of confession or a journey down the memory lane. And this is a smaller component compared to highest TDP, but it's still in some sense a soft hydraulic release. There is another way, which is ungeneration of affect, which is affected by understanding. That the understanding goes so deep, so profound, that the way in which the affect was generated is reversed, and an ungeneration of affect takes place, which is what happens in cognitive therapies. One can always ask a question, in cognitive therapies, how is the bottled up affect released? Because they are not using the hydraulic way. So it is happening by ungeneration of affect. Yes, please. Yes. In Vipassana also it happens, catharsis. In Vipassana both happen. There is a soft hydraulic release and ungeneration of affect. Because when you feel those pains in the body, they are somatization of those affects. That the hydraulic process is on, it is getting displaced. So it happens when you're observing an affect. You are observing an affect, so it passes through a wave kind of situation. It gets recognized, becomes active, becomes acute, and then it starts going down. So that is a hydraulic, soft hydraulic process. And when, because of understanding, something goes away, it is because of ungeneration. So in Vipassana, you find both soft hydraulic release as well as ungeneration. This release, whether it is hydraulic or ungeneration, you don't have much problem of calibration, but hydraulic, you definitely have a problem of calibration. That you have to calibrate the evoking of affect. If you evoke too much of affect, it is not constructive for healing. And what I call destructive affect mobilization. That you mobilize so much of affect which cannot be processed judiciously in a safe way. So that is destructive affect mobilization. I call it damn. And I always say damned if you damn. It's a very difficult thing. And this often happens, especially in ISTDP. People just go above the line. This can also happen in some meditative techniques which are based upon release of emotions, that one can just cross the line. Now, crisis is something very important in therapy. In everyday life also you will see that when there is a crisis, deep change becomes easy. The psyche becomes very malleable and soft and flexible in the time of crisis. What people say, experience is the best teacher. Because in intense experiences, people are ready to change the most rigid parts of themselves, which they will not change by any amount of therapy. So crisis is that state into which the whole of you is completely involved, and that involvement creates a different kind of malleability and flexibility. One crisis is when the person runs to you because he is in a crisis. That is a crisis of suffering, not a crisis of healing. We are talking about a crisis of healing. That a crisis can completely cripple a person and not allow him to do anything right, but a softer version of that, a softer crisis, can be a great opportunity. So we are referring to those non-crippling, constructive, softer crises, which are very conducive for healing. Like, for example, we talked, okay, so the first is crisis is an opportunity. So never miss a crisis, never miss an emergency session, because all emergency sessions are soft crisis. Maximum change can be affected, and much of it you don't have to do anything. In the emergency session, just listen to the patient. And more often than not, he will pose a question and give a solution to himself. He just needs the presence of yours, on whom he has already projected many things. Safety, omnipotence, and a lot of things. If there is no crisis, then we manufacture one. And the first easiest way to manufacture a crisis is silence. It's very awkward for two people to sit together and not talk. That is the cultural training, which is very different from people who really deeply know each other. They can be silent for hours. In Sherlock Holmes, there is a very good statement written by Arthur Conan Doyle. Dr. Watson writes it. Dr. Watson says, I and Sherlock walked together a long road without saying anything, as befits those who know each other intimately. So that is a very different state of knowing each other, where one can be comfortable with each other in silences. But the normal cultural training is not that. People are not comfortable with silences, and in social occasions, they fill up the silence with words, often useless and meaningless. So silence creates a crisis. And that creates that churning, that manthan inside of the person. And you can see that people are fumbling emotionally. There is a bit of anxiety, there is a bit of fumbling, they don't know what to do. And a few moments, something important comes up. So silence is a good crisis to create again and again. Some people want to experiment with it. And one person called me and said, I want a silent session. So I said, fine, I'm okay with it. So we did a silent session, 1 hour. And after the silent session, one should not do anything for about 2 hours and allow things to proceed, complete themselves, get a closure. And then start talking about it to somebody or to whoever you want. One way to create a crisis is to focus on feelings. Because as human beings, all human beings are comfortable with thoughts. Nobody is comfortable with feelings. We can keep thinking 24 hours, but we can't feel for more than 10 minutes. So if you look at three players in the psychic playground, thought, feeling, and action, we are all comfortable with thought and action. Tell me what to do, I will do it. Discuss with me and I will discuss with you. But feeling is something nobody is comfortable. So the moment I ask you to sit on the in the therapy room on a chair, action is ruled out. So one player is gone. Then I ask you to focus on the feelings. And you when go into thoughts, I say, let us put the thoughts aside and only focus on the feelings. So action is gone, the thoughts are gone. Now you're left with nothing but the feelings to focus on, and a crisis is created. Because focus on feelings is a crisis. Nobody's comfortable with it. And that crisis can be used to really activate and evoke deeper parts of the psyche. And when the therapy session is going too superficial in all the four directions, and the patient is using free association as a defense, it is good to use this tool to bring back the focus on feelings, and suddenly a crisis is created. And after that, even if you let go of this tool after a few minutes, the convergence and the focus is back in the session. And that defense of diversification is gone. Sorry, defense of diversion is gone. So any problems with any of this? Crisis can also be created by some creative things. For example, one tool which is used is the empty chair. I put an empty chair in front of you and I say, think your father is sitting on this chair and you want to say all that you wanted to say but you could not say. Can you talk to this chair? And a crisis is created. An emotional crisis is created. Or when you bring together conflicting emotions about the same person. That Friday you said you don't like this person, today you say you like this person. If you put both of them together, what is it? Now he is forced to either take a side or to integrate. He can't jump from one pole to the other alternately. Either he has to integrate or he has to be on either of the poles and let go of the other pole. And that's a cognitive crisis and also an affective crisis. Yeah.
Sir, I remember that during my early teens, I had gone to a psychotherapist in BM Institute, and I stopped going after the second session because the fellow would not say anything. I was so irritated, and I found it so pointless. Maybe there was transference also, but isn't that a major danger that if we stay silent, no crisis may happen?
True.
Yeah.
Or the crisis may be so large unconsciously, it becomes
Yes.
unbearable.
Right.
So that is where the calibration comes in. That in the initial sessions, you have to speak far more and bring silence in slowly.
Right.
Because initially the person does not know this process. And rightly, as you thought, a person can think nothing is happening. What is happening? I'm just going and lying down. Or I'm just going and sitting there doing nothing. He's doing nothing. I'm doing nothing.
Yes.
So then initially when deep internally nothing is happening, it is better to have more verbal communication and use silence as a tool much later. And again, you have to calibrate. With dependent persons, you will have to use it less. With narcissistic persons, you will have to use silence more. Because your remaining silent for 10 minutes can immediately create a crisis in the dependent, not in the narcissistic. So you use it based upon how many sessions have gone, whom you are working with, and slowly you bring in the element.
Yeah, fine.
You should also know, suppose a patient says, you are silent, he is silent, and he asks you what to do now. Now, there are two ways of looking at it. Yes, age of analysis is also important. The younger the age, the more you have to speak and more you have to be active.
Okay. Right.
With more mature people, you don't have to speak so much.
Okay.
Another important point is, has the person before being in therapy or not? If he's coming for the first time, then you have to speak more. And initially, lot of things about the therapy have to be explained indirectly to the person. So this psychoeducation also goes on in the session, because the whole setup looks very strange, because it's artificial. It's created for a healing purpose. It's not natural. So this is where the calibration of silence comes in. Which type of patient, what kind of session, and how to slowly bring it in, and also factor in the age of the person and also the culture. In some cultures, this may be extremely awkward not to talk. Yeah, I was talking about what to do about it. The patient says, what do we do now? Now, initial sessions, you can say, let the unconscious guide us. Just look inside and whatever is important will come up. So the patient looks inside and something important comes in. When you have crossed a particular line and the patient is ready for challenge, he is healed to the extent that he is no longer fragile, he is ready for challenge. And then again he says, what should we do now? There you can say, only you would know. But initially to say only you would know is not the correct thing, because the patient has come to you feeling you know. So you cannot say, I don't know. The patient might get a wrong information, the impression that you also don't know what to do. So instead of seeing this as empowering the patient, he may see it as your incompetence. So these things have to very, very contextually calibrated. They thought they misfire. Okay, so these were the general concepts. Now what we will do is, we will do in details some concepts like transference will go in details, as you see in the slide. Transference will go in details. Counter transference will go in details. Shades of silence we will go in details. So this is shades of silence of the therapist, shades of silence of the patient. And then we'll go into resistances deeper. Okay, what are the different types of resistances coming down? And then how to do the therapy, how to start the session, how much to speak. Should you start or allow the patient to start? Or does it change over the lifeline of the therapy? So doing the therapy. So it's 4:30. So any questions, or we can stop for the day? And I think we will need probably 2 more sessions to complete Techqnique. One for transference, counter transference, and silence, and one for resistance and doing therapy. resistance is very unique because Freud said something very important. He said, man will do anything not to let go of his misery. If the person comes to you, pays you, invests so much time, money, and energy, and after coming to you in the therapy session, resists change.
Men or women also?
Both. Both. The word man is so inclusive, it includes women.
Feel more of women. WOE.
So this will inflame the feminists. If I say the word man is so inclusive, it includes women, but the women is not so inclusive to include men. So if you want to add fuel to the fire, we can use this statement.
Hence you lose.
Sorry?
Hence I win. Hence you lose.
That's what they say. History is his story.
Yeah.
So such is the magnanimity of the word man. And with that, three men can conclude today's session. Continue in the next Monday. See you.